Good afternoon. My name is Blake Daniels. I'm the chairman of the Board of Commissioners here for North Oaks Health System, and on behalf of the board and management, we want to welcome all of you here. This is our second North Oaks Community Forum, and we're certainly glad that you took the time and effort to be here. We hope that you find our presentation today interesting and informative. We have just kind of briefly go over the agenda, then I'll introduce a couple of people. There will be an update about our strategic priorities, what we're doing here at North Oaks, including engagement and experience. Well, you can see probably behind me here. Also, there will be a time for questions, but we ask if you would, on everybody's seat, you should have a little form that looks like this. If you have a question, please write it down. They will be collected later, and then we'll go through questions like that. I would also like to recognize, before I turn the mic over to Michelle, we do have two other members of the Board of Commissioners here. There are 5 in total. 2 of them were out of town or otherwise unavailable this afternoon. But we have Ms. Jocelyn Lee and Dr. Bob Barsley from the Board of Commissioners that we work together. I appreciate y'all very much. Also from our foundation board, we have Dr. James Nelson, who also is General Surgeon Emeritus and also a former Board of Commissioners member himself. So without any further ado, I'm going to go ahead and turn this over to Michelle. And again, welcome. Thank you for being here.
Good evening, everybody. And I too want to welcome you all here this evening. The first thing that I wanted to talk about are our priorities, our strategic initiatives. Because when I first became CEO, one of the priorities that our leadership team wanted to act on was reaching out and collaborating with the community and our various constituencies. And we broke it down into 4 strategic priorities. The first one is engagement and experience. And we wanted to look at how best can we engage and teach our employees what our values are. And so we did that through what we call the 4 C's. Our values are communication, courtesy, compassion, and commitment. Commitment to both coworkers and commitment to safety. And we said, we want to make sure that we're being consistent, that everybody's getting exceptional care all the time. We want people to be able to refer us to their friends and family. So the Employee Engagement Council, which is comprised of employees from across our health system as well as leadership, one of the first things they did was develop this training video. We just unveiled it this week to our staff, and this is a video where we talk about we are the patient experience. It takes every one of us. And so we want all new hires. We're the number 2 employer in Tangipahoa Parish, and each month we probably get 2,000 applicants. And we onboard about 100 employees a month. And we wanted to make sure that they were consistently trained in our values. And we wanted to do that through demonstration. So I'm going to share with you now the training video that was unveiled this week that we will start using next week with all of our employees. absolutely have the best team members here at North Oaks. Each day, I'm humbled and inspired in the manner in which they improve lives every time, every touch. As you can see, we are the patient experience and how we treat and respect others. One of the things that we also want is for the community to tell us what are your expectations, because many times we are so accustomed with our terminology and we speak in acronyms that we forget the people who don't live in our world every day may not understand. So another part of the Engagement Council outcome was for us to establish a council of patient and family advisors. This group is going to help us provide patient-centered care. We're going to do that through dignity and respect, through collaboration, sharing information, and participation of patients in their care. We want to be known for exceptional care where we're different. We want to have that be our product differentiator. But the only way we can do that is through your involvement. So like Uncle Sam says, I want you. Well, we need you too. We need you to be on our focus groups. We need your stories, your experiences, both positive and negative, so that we can learn from them. And we want you to serve on our patient and family advisory committee. Because let me give you one example. Many times we'll say we ship that patient to Children's Hospital. Well, we actually don't ship anything. We transport lovingly that child to another facility. Just changing that wording from we shipped versus we transported your loved one makes a big difference in somebody's mind. So we want to take a step back and talk to our family and patients and have them walk through our facility through their eyes. We want them to be the voice of our patient and family members. We want them to work with us to deliver the highest level of care. We want different perspectives, not just ours. And we're going to do this through shared expertise. I'm going to show you a video next, and to me this summarizes what we're trying to do with our new Patient and Family Council of Advisors.
3 o'clock in the morning, I got up, and when I got up, my arm fell and banged against the wall, but I didn't feel my arm. And that is the most bizarre experience that I've ever had. Stranger than that was realizing I'm having a stroke. Going into the emergency room changes everything. I'm scared, obviously. It's as if you have no power, you suddenly become anonymous, and you're looking around at the emergency room thinking, oh my God, this could be it. As the doctor walked by, he got down on one knee and he smiled and put his hand on my knee and said, tell me what's going on. And he did it with a kind of we've got time for this. He did it with compassion. He did it with a lot of heart. It was like there wasn't anyone else in the room except the two of us. And for that moment, I wasn't afraid. For that moment, I wasn't alone. And in that moment, I felt like there was something good that could come out of this. And I decided that at that point, the hospital was going to be my family, and it was actually a positive experience from that point forward. Patient-family-centered care means let's find out what the patient thinks of this experience every step of the way and how we can intervene in language and in behavior in a way that makes sense. So I joined the Patient Family Advisory Council in order to figure out if there's anything I could do, given my experience with my stroke, that would be helpful. Looking at all the different things that the hospital could do from the patient's point of view. And I noticed things like papers that we had, forms that we had that we gave to patients that read like something that a lawyer might have sent to the AMA. We were thinking together as patients what it's like when you're overwhelmed with whatever's going on with you, trying to make sense of something in medicalese. It needed to be more invitational. So what we did is we looked at all the different things the patients signed and looked at the conversational English and how that could work. So we revised, I think, probably 8 or 9 forms. Doesn't seem like a big deal that all of a sudden we have a whole different way of presenting ourselves to the patients. It's the hospital making a commitment to hear from the people they're serving and have it be as important as the service they provide. That is a huge impact. For a very long time, what patients said was just what patients said. Now what patients say is part of what drives the system. My name is Bob Lucken, and I believe that listening to patients transforms everything in healthcare.
And listening to our patients is crucial if we're going to be successful in the future. And so we've established a planning committee to have our very first Patient and Family Advisory Council. And so at this time, I'd like to recognize 2 members of that planning committee that are here from our Board of Commissioners. Again, you've already met her, Ms. Jocelyn Lee, and then Ms. Mary Parasco. And we wanted to make sure that we also brought in a member of the Parish Council as well. Mr. Vial couldn't be with us tonight, but we also have representation from our Parish Council on this committee, as well as patients and community members. The committee's been working every week for 2 hours a week to lay the groundwork, to establish the bylaws, the training manual, and what we're looking for in members of this council. In November and December, we're going to finalize the plan and present it to the board and begin recruitment. And then in January, the members will be selected and the first meeting will be at the end of January. So we're looking forward to changing how we provide care here. It's all going to be the way the patients want it through their eyes. A next priority for us is quality and safety. And I have to tell you, we're continuing to work and make strides to improve our overall care, to move us from average to both good and excellent. However, the government doesn't keep up with our progress. So instead, I brought 2 members of our medical staff and of our leadership team to talk about what they have done recently within the last 6 months to improve the quality of care that we're providing you, the community. The first one that I'm really excited about is Dr. Robinson. Dr. Robinson is our Chief Health Informatics Officer. And if you were here for our last community forum, we talked about his predictive analytics. Well, just recently, Dr. Robinson and one of our nurses, Colby Tyler, got back from Epic, which is our electronic health record. There were over 10,000 people in attendance, and they have over 60% of the market. And North Oaks was the first hospital in the United States to develop predictive analytics where we could show his modeling actually improved and saved lives right here in Hammond, Louisiana, by their efforts. Following Dr. Robinson's presentation, Dr. Pelche, our Chief Medical Officer, is going to come up and talk about the opioid crisis in our parish and what he and his committee are doing about it to save lives in our parish with opioids. And then, hot off the press, or I would have asked him to join us, Just yesterday, one of our new neurointerventional radiologists did the very first in North Oaks history, first time ever done in Hammond, and it was embolizing a brain tumor prior to a surgical resection. And this couldn't have been done here before, but it's because of the caliber of physicians that we're bringing in, and he saved that person's life. This person may not have made it to another community. That's the type of care we're providing here. So with that, Dr. Robinson.
All right, thanks, Michelle. As Michelle mentioned, last month, Colby Tyler and I, along with some other representatives from North Oaks, went to Epic's user group meeting. It's an annual meeting of over 10,000 customers. And convened annually. It was particularly significant for us, as Michelle also mentioned, that we were told we were the first one to implement the sepsis risk predictive model and combine that with the decision support system to detect and then notify our caregivers of a patient's sepsis risk or deteriorating condition. We thought we'd talk a little more about that. I mentioned that at the community forum last time that we were just going live with it, so now we have a little bit of data about what we've done. You might wonder why sepsis is such an important disease to address, but at least 250,000 Americans die from sepsis every year. If you compare that with heart disease is a little over 600,000. So sepsis is a pretty big player compared to heart disease. For coronary artery disease, which is basically heart attacks, for lack of a better description, it's a little over 350,000, so sepsis is close to that. Annually, about 1.5 million people get septic during the year. If you want to compare that with something else, about 250,000 women get breast cancer every year. Okay, so it's about 6 times the incidence of breast cancer. So pretty significant disease state, and it's something we wanted to try to address here at North Oaks. About 33% of all mortality in hospitals is usually related to sepsis. That's not our hospital, that's across the country. So with that in mind, we want to do something about it, and that goes to the implementation of our sepsis predictive model. It's a medical emergency, sepsis is, and it has to be treated quickly when we find it. 80% of sepsis cases occur in the community, so they'll show up at the emergency room already septic. 20% of them may become septic during the course of staying here. So we have to pick up the patient not only when they come to the emergency room, but also if they're already staying up on the floor. So we had to develop a model that could work in both situations. Our alert runs in our computer system, and it updates every 15 minutes, looking at different parameters on the patient, about 88 different measurements that we take on patients, from things like blood pressure and laboratory values to things such as history. Even it can be things such as previous surgical conditions. And it continues to run, and when it reaches a certain threshold, it alerts the caregiver that the patient may be septic. It gives them some options of how to help treat sepsis, but the main thing that it does is it gives them tools right at their fingertips at a time when they need them to help take better care of the patient, and that's what makes this so important. It also continues to run until the patient is discharged every 15 minutes. So once you show up, it's checking on you. So anyone can get an infection. I think this shows why it's so important in our community. It can happen to anyone. Lung infections, urinary tract infections, skin infections, intestinal infections can all lead to sepsis. As I said, at one time about 1,000 people a year will come into North Oaks and they will be septic or become septic. We want you all to know that here at North Oaks that we continue to try to do everything we can to reduce this deadly disease as well as many other diseases that are associated with different types of infection processes, and we've been pretty successful, we think. This, this graph isn't a little better now at this point, but if you can see, these are ratios, so the numbers are statistical ratios. We've had the lowest mortality at North Oaks in the 2 months following the implementation of our model. We've had the lowest mortality related to sepsis that we've ever had, and I don't know if this points at it or not, but the top line is the number of living patients, the blue line. The yellow line underneath it is the number who passed away secondary to sepsis. It's not always a curable condition. And then at the bottom where you see where the blue line has dropped, those last 2 months were our mortality ratios related to sepsis, which as you can see if you go back are lower than it's ever been. Now, that's not only a tribute to the model, it's a tribute to everyone that works at North Oaks, because we have a lot of moving pieces in complex technology. We have an IT department that helps keep our systems up and running. We have lots of analysts that work on it. We have nurses and physicians and other clinicians on the floor who see the model, and they actually have to deliver care to the patient, all the way to make sure that the IV poles are clean and the bags that have the IVs in them are ready to go. We estimate that it takes probably over 200 people to care for a patient or to provide the infrastructure that supports a patient for something like sepsis. So I just thought we'd share some of those stats with y'all and let y'all know some of the successes we've had since we saw you last. And now I think Dr. Pelche is going to come talk about the opioid crisis.
Good evening, everybody. I appreciate you guys all taking the time, caring enough about your hospital to come out and discuss this, which is much more than the hospital. If you're not familiar with opioids, we'll spend a little time talking about those first. We naturally have receptors in our body, mostly located in our nerve endings, but we have multiple receptors in our body that are opioid receptors. We release natural endorphins. Everybody's heard of runner's highs. That's when your muscles break down. We release these chemicals so you don't feel that pain. But remember, pain's not always a bad thing. But this is a natural substance. This substance is derived, let me go back one. This plant here, that's the opioid poppy. There are a bunch of different types of poppy, but this is a specific type. This is the seed pod from that particular plant. It's cut with a knife, and this whitish liquid comes draining out and eventually kind of becomes this black tarry substance, which if you've ever seen any of the PBS specials, you see the guys in other countries sometimes scraping that stuff off. Well, that's the raw opium, and which contains about 26% morphine. That's where morphine comes from. The problem is very old. This is really this slide refers to the problem in the United States, but this goes back eons. It's a joke that when I was talking to an earlier group that this is really the who's who of the Old Testament. The Sumerians first had this in 3400 BC, this technology, and they passed it to the Assyrians, who passed it to the Babylonians, who passed it to the Egyptians, who passed it to the Phoenicians, who passed it to Arab traders, who passed it to the Chinese, and now it's everywhere throughout the earth. But in the United States, where it really became a problem is back in the Civil War. That's about the time we moved from we synthesized heroin from morphine. And during the Civil War, it was actually a pretty good drug because it gave a lot of euphoria, which unfortunately at that time meant we could do field amputations a little bit easier. Sad fact, but that's sort of where heroin used. Nowadays, heroin is not a medically useful substance from a medicine standpoint, but still has an issue. Unfortunately, what we saw from the Civil War is a lot of addicted soldiers, and they came back using the tinctures of morphine, and we saw literally 400,000 to 500,000 soldiers just in the Confederate war addicted. Modern problems associated with it. This is an article from the New England Journal of Medicine, probably our most trusted journal in the United States. The very bottom of this journal article talks, and these were, one was a doc, one was someone else, and this is a letter to the editor back in 1980. And what happened with this was they surmised from their brief, limited research that the development of addiction was rare. This was about the same time that we moved to long-acting opioids as a means so that you didn't have to take them every 4 hours or so. We developed some of these new products that were out there. The pharmaceutical company took this one article, and I was in full practice about that time. They marketed to us saying that here's the data out there. It looks like these drugs are going to be vastly superior to the other, and the amount of prescriptions went through the roof. To this day, the United States has 5% of the world's population, and we only in the United States is 80% of all opioids used in the world. Here are some of the common opioids. This is their generic names and then some trade names that you may recognize. I think this graph, which may be hard from the people in the back to see, that black line is morphine. That's what everything's compared to. And different properties of different drugs have different amount of effect. If you see at the bottom right is acetaminophen or Tylenol and aspirin, and they're about 130 times less potent than morphine, while fentanyl is actually at the top, and that's about 100 times as potent as morphine is. Let's shift gears a little bit and look at local stats. So we're going to look at these are encounters that have occurred over the past couple of years at North Oaks. So you'll see that they have 721 unique patients and 826 hospital encounters. That's because some people, unfortunately, having more than one overdose. Now, let me point out, overdose is not just from opioids. This is from all substances, all drugs, and we'll look at that in a minute. But you can see there's some distribution things that don't know that necessarily matters to, other than to try to identify where some of this occurs. We have, it seems to be slightly more of a female disease than a male disease here. We tend to see a little bit more Caucasians than African Americans or other races. You have our graphs get kind of, our statistics department, sometimes for us to read them, can be a little bit confusion. And unfortunately, this is small font. But at the bottom, what you're seeing is sort of some of the statistics. You tend to have more non-employed, more disabled people. You tend to have a little bit more single than married people fall into that. But the reason I brought this graph in is you can see the equal distribution in age groups, really from when people turn adult until about retirement age. So from about 18 to 65 or so is where we see sort of, it's just all the way through those. This is local areas, and so the top is Hammond and Ponchatoula, but this is and male and female. What you see here is probably a better representation. This is the using the addresses of the people that show up that are coded with overdoses. This is the ones that at least come to North Oaks, which makes sense. I mean, we're obviously sitting right in the middle of that, but there's a lot of dots there, unfortunately. Pink and blue are not male and female in this one. What you have here, and you guys, small font, but these are the different types of drugs. So like I said, this is not just opioids, but you have amphetamines, barbiturates, opiates, benzos, cocaine, THC, which is marijuana, and PCP. And this is all the same people, but you can see that where we see a lot of pink, which means that's what was in their drug screen, because a lot of people have multiple drugs. Most people that overdose don't just have one. The problem is opioids and benzodiazepines. Benzos are your Xanax and Valium and those kind of drugs. So, what does this look like? An opioid overdose is going to, first of all, people are not going to be feeling any pain. They're going to be high. That's what the euphoria is. They're going to feel that sense of drunkenness. One of the things that quickly makes us suspicious and is sort of unique to opioids is, you'll see the eye here, it's a pinpoint pupil. So a lot of times when they come in the ED and we see that, we immediately think opioid overdose. We have receptors in our gut. It's actually a fantastic drug for diarrhea and loose stool. They used to have a tincture of morphine that you could buy over the counter until probably the early 90s is when they stopped selling that. It releases histamine, so all the things you get when you have an allergic reaction to something, sort of hay fever type symptoms you'll see with these people. And the one that kills people is the respiratory depression. If you take too much of these opioids, you will stop breathing, and that's where people die. Luckily, in the past few decades, we've developed a drug to, sort of an antidote for it. Narcan, or naloxone is the generic name. It comes in a couple of different preparations. Here at the hospital, we don't necessarily use the nasal spray as much as we would use intravenous, but the nice thing about the nasal spray is that it can be used in the field. So EMS, police have started to carry these in different communities because they're sometimes the first on the scene, unfortunately. Works in a couple of minutes, reverses the effects of the overdose. People hate it because now they immediately go into withdrawals, so it's not a fun drug to get if you're addicted to opioids. And one of the problems, and even if a family member, somebody would get this medication, you still need to bring them to the hospital because this drug lasts a shorter period of time than a lot of the opioids last now. So the effects of this will go away and the opioids may come back on board. So what are we doing about it? We're going to talk about federal, then on the state level, and then what we're doing here at North Oaks. Federally, we did get some help from the CDC. They've started this Turn the Tide campaign and came out with some recommendations about what we should do. These recommendations have been taken on at the state level and certainly here at North Oaks, and include things like, common sense things. Try not to use these medications unless they're absolutely needed. And let me stop for a second and say, these drugs have merit. They are good medications to have. They are fantastic medications for acute pain, for long-term cancer pain, you name it. They have a number of absolute properties. They should not be taken away. They're good drugs to use. That being said, how we use them has been the problem. Really using them for a maximum of 3 days in acute pain, and going back to the short-acting medications, which we had gotten away from, and moving away from the long-acting preparations of OxyContin is one that most people are familiar with. So on the state level, just recently we had a couple of bills passed and become law that do affect physicians. And to be honest with you, sometimes physicians are upset when we get told what we have to or can and can't do. But in this case, I'm not sure that most physicians haven't said this isn't a bad thing. The bill actually, there's two bills that we'll talk about. The first one really limited us for acute pain to a 7-day supply. Docs sometimes like to be able to tell patients that are coming in that want more than that. I wish I could, but the law says I can't. So sometimes it helps them sort of have that conversation. Two other things have to happen in this particular bill, and it's having the conversation about the opioids and the risks that are associated with it, and letting them know, even though I gave you, 20 pills, a 7-day supply, you don't have to fill them all, and you certainly don't have to take them all. The second bill came in relation to the prescription drug monitoring program. Louisiana has had this program on for a couple of years. The Board of Pharmacy has this particular program. All the docs have gotten registered. You have to do sort of a little class about it, and you can log on, and I can take anybody that shows up in my office, at the emergency department, any computer that's got internet access. I can look, all the pharmacies participate, and essentially what it is a database, a data warehouse that I can go and look and say, see if Michelle got a prescription from anybody else and when the last prescription. I looked myself up the other day and saw that after a surgery I'd gotten it 3 or 4 years ago. It told me exactly who the doctor was and how many pills were prescribed. So what that stops and helps to stop is the doctor shopping that happens. Patients going to one doctor, getting a short supply, going to the next doctor. At least the doctor can look it up and say, and our emergency department's been using this program for a while. It's now law that you must look it up for any new prescription for acute pain. So at North Oaks, what are we doing? This team has been meeting for a year or so, talking about the problem, what can we do, what do we do locally, how do we fix it. You can see there's multiple members from different specialty, trauma surgeons, emergency department, nurses, patient safety nurses, pharmacists, a whole plethora of experts in the area. We've been meeting, talking about it, and a couple things that we're going to concentrate on. First, again, we're going to continue to inform the public of what we're going to be doing and how we're going to be changing our prescribing habits. You start to see these signs in the hospital, but especially in the emergency department. These are things that are saying, if you're here for chronic pain, because a lot of our opioid-seeking patients show up in the emergency department, unfortunately, especially on Fridays and Saturday nights, because they say I can't get in touch with my doctor. These are just going to be signs that say, well, that outlet is gone. We're not going to be treating chronic pain anymore, and we're certainly not going to be giving long-acting opiates, and we're not going to be refilling those prescriptions that you accidentally flush down the toilet or anything. We get lots of stories. Oh, second thing, and maybe the most important thing, is how we talk to the public and our patients about pain. Dr. Robinson and I talked about this the other day. 10 years ago, we actually had a 5th vital signs. Currently, there's 4 vital signs that have always been classic in medicine: your respiratory rate, your blood pressure, your heart rate, missing one, temperature. And they started a 5th vital sign because at that time, everybody was saying we beat the pain deal, and it was a pain scale. You had to ask your patient how much they were hurting. Then there started even being regulations that said you must treat certain types of pain, and we got pushed way too far the other way. So we're going to do a couple of things. We're going to have conversations about our patients and about pain that they should expect. You should hurt a little bit after surgery. We don't need to make your pain zero anymore. I think we went way too far and I say we, not just North Oaks, the whole nation went way too far in that we can just eliminate pain. We need to have those conversations about, listen, I'm going to send you home with a couple pain medications after surgery. If you need it, take it. Maybe try some Tylenol first, but if that doesn't work, then you can go ahead and have one of these. If after 2 or 3 days you're still hurting, I want to hear about it because maybe something else is going on. We want to set expectations with patients about experiencing some pain, because we literally used to send patients home and tell them, I don't want you to hurt, so take it before you start hurting so you don't hurt. Bad advice, but that was the going trend at the time. And unfortunately, what we've seen is overdose deaths result from opioids. So there's a couple of graphs here. They're not fun graphs to see, but they are fact. And this is why it's become a crisis in the past couple of years. You just see the exponential deaths, and it's due to a couple things. One, it's due to everything we just talked about, but it's due to heroin coming back as well. And you can see that what color is it? Blue line at the bottom. You see the amount of heroin. So a couple of reasons that occurred. First thing is heroin has become exceptionally cheap. There's a market for it now because people have moved away from illegal street drugs to prescription drugs, and heroin is an opiate. So we've seen a market for it, and we've seen it become extremely cheap. It used to only be, I think 90% of the world's heroin was from Afghanistan. A lot of it comes from Mexico now. It's become cheap to get. So the street price has gone way down, and it is accessible, and subsequently what we've seen is a significant increase in deaths from heroin. We will see that in our community. We will see both the heroin and we will see deaths from it for two reasons. One, we're changing our ways. So we're going to have a wave of people that have some opioid problems that may turn to this particular drug. Unlike what I would prescribe for them, where I can give them an exact amount, what you get on the street, you never know what you're going to get or what it's laced with. Strychnine is a common additive to heroin. So you can imagine the people that will die because the little 1 milligram that they took last time may only be 100 times as potent as the one they're taking today. So they never know, and so you'll see a lot of overdose, and that's the sad part about it. So I would emphasize again, opioids have their use, but there are a lot of things that are happening on the federal, state, and here locally to try to help. I am going to do this talk to the Parish Council on the 23rd. I think it's important that our local leaders hear this. I hope they know that they should expect. They probably already know that probably local police force has been telling them they started to see heroin enter the area more than they had in the past, and we do expect that. Again, what we're trying to do, and what most of these programs are doing, are preventing new opioid addicts. So a lot of the things that we are taking on nationally is going to help. We're going to certainly need detox centers, help in the emergency department with those people that are either taking heroin or withdrawing from opiates, because it will happen. So we'll see a little bubble. So it may actually, unfortunately, get a little worse before it gets better. Thank you, guys.
All right. Good afternoon, guys. My name is Percival Kane. I'm the Chief Ambulatory Officer here at North Oaks, and I get the pleasure of kind of introducing you guys to some of the new providers and the new physicians that we've hired on within our system. So I'm going to start with Dr. Jolanda Harris, who's Med Peds, and Dr. Brittany Hadier, who's a Family Med physician. They are actually at our Family Med Hammond site, right up the way. The next one is one that we're really excited about. We've hired 2 endocrinologists for our physician group. This is a service that our community has needed for quite some time. So we have Dr. Khan and Dr. Corey Majors, and they've both been with us since the summer, and they've kind of just jumped right in. The next one we have is our docs at our primary care Hammond site that's actually on this campus on the 2nd floor in the building right next to us. we have Dr. Becky Batiste, Dr. Juan Martinez, Dr. Ryan Rose, and Dr. Farhan Siddiqui. Dr. Ryan Rose actually is kind of interesting for us because he's actually not only a family med doc, but he also is board certified in sports medicine as well. Next one we have is Dr. Joseph DiPietro, who is a physiatrist. We have Dr. Justin Folks, who's a new pulmonologist for us. And then Dr. Zach Leinert, who is a IR radiologist, and I am assuming he's the gentleman that actually performed the surgery or the procedure that Michelle was mentioning to you guys a little earlier. Next we have Dr. Victor Linden, who's one of our psychiatrists, and as Rob had mentioned, not only is he getting a lot of business within the community, but he's also getting the business within the North Oaks as well. The next one is Jeffrey Whitty, who's our orthopedist. And then the next one we have is Dr. Karan Garapati, and I'm hoping I'm pronouncing that correctly. He's one of our hospitalists. Dr. Timothy Hadier, who's one of our emergency medicine physicians. And then Dr. Kimberly Hodge, who's one of our OB docs for North Oaks OB, and we're really happy to have them as well. Last but not least are Dr. James Moises, who's an emergency room physician, and then Dr. Patrick Sheehan, who's once again another emergency room physician. So really excited about having all these new docs. We brought in about 20 providers, or 20 physicians specifically, within the last couple months. So this is a big win for us, big win for our community here in Hammond, Ponchatoula, as well as Livingston Parish. Last but not least, I'm going to part with this fun news. North Oaks is, for the 8th time consecutively, identified as the best places to work. So you kind of heard Michelle talk about how really are excited about the work that we do. Well, it's really nice to hear that the community actually is very receptive to that as well. So thank you guys for voting us best places to work. Michelle?
Okay, so you've seen 3 of our priorities. Those priorities from experience to quality, what we're doing, to a focus on our people, making sure we're hiring the best people, and then we're providing an environment where people want to stay. The next priority for us in the final strategic is efficiency. And one of the things is we must be good stewards of our dollar, because every dollar matters. And when talking to our patients, one of the things that we heard the most from them is we don't know what our bill's going to be. So what we did was we established just recently a patient financial center. This patient financial assistance center, they are quoting what your patient responsibility is going to be, because nowadays it really doesn't matter what our charges are, because nobody pays charges. Everybody negotiates a deal, whether it's the payer or the employee, and then or the patient or the employee, we set up payment plans. And so the reason why we do that is we want people to know what's their responsibility. We don't want to add any stress to their illness, wondering how they're going to pay for it. In addition, we screen patients to see if they qualify for any type of government assistance, charity care, or if they need a payment plan. The emergency department, federal law protects those who really need us in a true emergency through what's called EMTALA, which is the Emergency Medical Treatment and Active Labor Act. It means we have to treat the patient, stabilize them before we can ask about their ability to pay. That's a federal law. In our community, we have over 80% of our patients are funded by the government through Medicare, Medicaid, or no pay. Those government payers or self-pay do not cover our cost. So 80% of our business here at North Oaks doesn't cover our cost. So the other 20%, which is the insurance, are helping us to provide all that we do for the community. So we are a true safety net hospital. Our fiscal year just ended on June 30, and we ended in a $5 million deficit. and it's because of us being a safety net facility. And so we need your help to reach out to get everybody to use us, not just those that are poor or indigent or those that are on a federal payer. We need everybody to support our hospital, because if not, we won't be here for the community. We are the #2 employer in the parish. We have a payroll of over $162 million that we reinvest into this community. We're also one of 5 trauma centers in the state of Louisiana. There's a reason we're the only hospital that delivers babies. It's because it's a loser. There's a reason we have only the full service emergency department in our parish. It's because you can't make money in an emergency room. But we don't think about that. We think about how can we meet the community's needs? How can we improve lives every time, every touch? And we need your help to do that. So with that, I'm going to ask Melanie and Tracy to pick up your questions, and we'll go ahead and answer your questions. If you have a question, if you'll hold up your card and they'll grab it from you. Okay, the first question is, what is happening at the driving range on North Oaks Drive? Does it have anything to do with North Oaks? I'm looking over there to Joe Thomas from the parish, because it's not our property. We have no idea. It's within the city limits of Hammond. We've been told that they've been working on some utility right away, but at this point, nobody has filed a permit to build anything on it. So they've just cleared it to get ready for the widening of Club Deluxe and then for the utility connection. The next question is, how many patients is assigned to each nurse on the floors and in the emergency room? And that depends upon which nursing unit you're on. So for example, if you are in our ICU, our medical ICU, depending upon what's wrong with you, what we call your acuity, how ill you are, it'll either be 1-to-1 or 1-to-2. In our surgical intensive care unit, same thing, depending upon 1-to-1 or 1-to-2. If you go out to our step-down unit, it's 1 nurse to 4 patients. If you go out to our surgery unit, it could be 1-to-5 or 1-to-6. They look at how sick and how much help each patient needs. In the emergency room, I'm not quite sure, because they do team nursing there. So I don't know if, I know each team has a total of 7 patients, but it's comprised of 2 nurses, a patient care tech, and a doctor. And then they have a floating nurse. So I don't know if I can give an exact number for the emergency department, because it's team nursing down there. Any other questions? Well, on behalf of our board, we just want to say thank you for coming, for being interested in your community hospital, and for helping us to make a difference. I would invite you, if you would like to be a part of the Patient and Family Advisory Council, to please let us know. Leave your name and phone number on the card in your email, and we'll reach out to you as we start taking applications for that. Because we want to run this hospital through the eyes of a patient. It's why we're here. Thank you again for coming.